This is a routine phaco surgery done in a grade 3 plus nucleus sclerosis with a pretty dense posterior subcapsular cataract. So after my incisions and staining the capsule with trypan blue, I am going ahead and performing my capsular access with a 26 gauge needle. All seems to be going well. I need to keep this rhexis down to 5.5 mm in diameter, and that's pretty easily achieved. The next step would be, of course, to go ahead and do the hydrodissection after decompressing the chamber before entering with the hydrodissection cannula, and that's a good fluid wave. There's also forward movement of the nucleus. I just put in a few more waves just to make sure. And with the third wave, the nucleus actually prolapsed out, so I have to very gently nudge it back in. I don't want to phaco in the anterior chamber in a one-eyed patient. I've also put in a mixture of chondroitin sulfate and sodium hyaluronate for additional protection of the endothelium. I then take my Sinskey hook as a chopper, and I plan to do the direct vertical chops. And that's well executed. I have to make sure I get at least 4 segments. This is almost like a combination of the woodcutters and the quick chop method. There comes out the first segment, and this is a pretty large segment but very easily phacoed. Just twist my phaco probe and get the rest of the pieces as well. And with that, it's time to I first take out that small nuclear bit and then aspirate out all the cortex from the capsular bag. Now, this is not a good maneuver. I think it is better to take time and come from the other side. Yes, you can get away with it sometimes, but I think that would be safer if I had changed hands. Anyway, it's done. Just cleaning some cortical fibers on the posterior capsule at the superior part. You can see I also do it with my visco. This is a very useful trick. You can just literally scrape off those fibers. I'm now injecting my single piece hydrophobic oil directly into the bag. And the trailing haptic remains to be teased into the bag. That's easily done using a Sinskey hook. Wysinski hook is probably the most versatile instrument devised in ophthalmology. I keep saying this time and again. I know I sound like a broken record, but that's the truth. And then remove carefully all the viscoelastic from both the anterior chamber and as well as from uh, the the HPMC trapped behind the IOL as well. I do spend a lot of time trying to take out every bit of HPMC. Invariably, there will be some left, but it doesn't matter. That will absorb. Then put in my intracameral antibiotic, hydrate the wounds, and conclude the surgery. Thank you so much for watching.